Welcome back to the next session here at Conference 2023. Really important one, this. This is called Workforce Under Pressure, a true picture of police wellbeing. An amazing panel. In a moment, Sue Honeywell will be with us, wellbeing co-lead for the Federation, of course. Paul Williams, wellbeing co-lead too. We're also going to have with us Andy Rhodes from the College of Policing and Professor John Harrison as well, Chief Medical Officer at the college. But to start things off, it's over to Sue.
Thanks, Ian. 21st century policing is a complex profession. As other public sector organisations have been contracting, the police have increasingly stepped into that space, occupying and assuming responsibilities for issues that are best responded to by other agencies. 40% of incidents attended by police are mental health related, a staggering percentage, which underlines the breadth of work officers are managing alongside more traditional police work. At the same time, officers' pensions have been eroded, assaults on officers are increasing, and the cost of living crisis has squeezed pay to such a level that we know some are forced to resorting to food banks to stay afloat. On top of this, media reporting paints a picture of incompetence and immorality within the service that is not a true representation of the overwhelming majority of decent, hard-working officers. There are many elements that impact on police wellbeing. An inexperienced frontline, burden of extremely heavy workloads, attending distressing incidents on a regular basis, student officers having to learn a complex profession alongside significant academic programmes, that repeated exposure, that ongoing trip, investigations being played out via social media, and the significant impact this can have on senior investigating officers and those trying to run complex investigation, all whilst supporting families going through incredibly traumatic times. Shift patterns, the constant need for the changing of shifts, cancelling of rest days when things happen. It's the police that are getting called on. The lack of annual leave that you're able to take. As I reiterate, 21st century policing is complex. Is it any wonder we've seen a slight increase in long-term sickness absence and an increase in officers being placed on adjusted duties? Adjusted duties highlights that they've been on recuperative duties for over 12 months. Statistics show us we have a workforce under pressure. Notwithstanding the impact on officers' mental well-being, we are also seeing an increasing trend of officers being placed on adjusted duties as they've been unable to access treatment through the NHS for physical ailments. Often these injuries are sustained on duties. The delays in the NHS not only impact on society, but also policing, with officers being placed in back office functions while they await surgery, rendering them non-deployable. And I can speak from personal experience on this point, having been driven at, assaulted and injured on duty in 2020, and having to wait almost 2 years for surgery for a knee injury. The impact of these delays not only affects officers' physical well-being, but can often have a detrimental impact on officers' mental health. These are just some of the headlined issues faced by our members. We must challenge chiefs to do more to protect the rights and working conditions of our officers. More importantly, divert that work to the most suitable agencies and support the hard-working and decent officers who serve and protect our nation. We are working really closely with our key stakeholders to address a number of issues that impact on officer wellbeing, and some fantastic preventative tools are now being used by some forces. But there is a clear evidence that more needs to be done. I firmly believe if wellbeing is invested in, we will start to see a changing picture. We have started to see some results from some forces using preventative measures and products used to track trauma. But forces need to ensure they have the right support in place to offer supportive follow-up to ensure they do not break our officers. For far too long, forces have waited until officers are at breaking point before offering any intervention. Last year, the Policing Covenant was laid before government, and work on this continues. We've already seen an investment in the form of a Chief Medical Officer, who I'm looking forward to hearing from today. We're also starting to see chiefs invest in projects like Right Care, Right Person. But as I say, some of our officers are reaching that burnout point, so more needs to be done. The causes of absence, and in particular mental health related absence, are many, but with officer numbers proportionally at an all-time low, officers' morale at its lowest, and the workloads at their greatest, it can be no surprise that we are witnessing extremely high levels of officers signed off for mental ill health related reasons. As the Home Office demands that forces investigate all crimes more thoroughly, but without providing the resources, financially or otherwise, to meet this expectation, refusing to meet pay demands and becoming increasingly outspoken in areas that are best for policing and not politics, we fear that these figures will remain high or even grow in number, when instead more should be being done to remedy the crisis in policing and keep our members out there protecting the public. We're now going to see a short film from the College of Policing around purpose, and this is about a new recruit joining the police service.
What did you get out my house?
I'll get out your house as soon as you put the knife down.
Come on then. Show us your warrant card.
Why did you join up?
I said I'd do it.
You don't need to worry, Alfie.
Stop there.
Why did you join up?
Want to see the bruising, eh? You can't look at it, can you?
Why did you want to become a police officer?
And shortly we'll be hearing from Paul Williams, who's co-lead on wellbeing. Before we do, we now have a presentation from the College of Policing. Very pleased to welcome some faces and names that will be very familiar to you as well. Andy Rhodes is with us, wellbeing lead at the college, and also Professor John Harrison, who's the Chief Medical Officer at the college as well. Gentlemen, over to you. Good morning to you both.
Thank you, Ian. I'm going to start off the presentation today, then I'll be followed by John, Professor John Harrison, the new Chief Medical Officer, a very new role for us, and as Sue said, what we see as a real step forward. I'm going to talk today about what we know now that we didn't know, say, 10 years ago, and more importantly, what it is that we should be and must be, and in some forces are doing about it. So I'm going to cover off a few of the headlines, and we'll leave plenty of time after John's session, who follows me, for questions and answers. So please do make sure that we get some of those through. So if we can just go on the first slide for me, please. So the thing that we, I think, can rely on now that we didn't know 10 years ago is that we have got a phenomenal amount of research, employee voice, as we call it, through surveys from organisations like the Police Federation, the Supers, and we do a very large National Police Wellbeing Survey every year. This year it closed with over 40,000 responses from individuals across police, and that these are independently evaluated. We also have really good links internationally to police forces in Canada, Australia, the US particularly, and we share a lot of research and practice with them. But that ranges from really sort of specialist areas like trauma, PTSD. People would be aware of the work that Police Care UK have done with Dr. Jess Miller and the like, and Professor Neil Greenberg, people like this. They are all contributing to us understanding what it is we need to do to support our people in this weird and wonderful and often harmful world of policing. So the one thing that comes out for me after 8 or 9 years of this is there is one big message. It's not always the nature of the work itself that is making our people ill. We can say now, and we couldn't say this 8 years ago, that the way we run our organisations and some of the issues that Sue alluded to, i.e. doing work that isn't necessarily what we thought we should be doing, that isn't what we joined to do, that doesn't give us meaning and purpose necessarily, is very damaging to our mental health and well-being. Workload, resources, toxic cultures, poor leadership, poorly delivered technology, all these things we call organisational stressors, hindrance stressors. And we have independent research now that say they are primarily driving quite the vast proportion of negative indicators on our wellbeing service. And this ranges from intention to quit through to psychological detachment, fatigue, feeling supported, etc. So that's one big message for me, is that I'm going to talk about a lot of things that are directly related to supporting specific elements of the nature of our work. John is an occupational health specialist. The whole point of occupational health is that you design systems that are tuned into the specific occupation that you're working in. And so that's what I'm going to talk about now. So the police covenant, it's year one. We spent, I would say, to summarize it, fixing things that, getting things done that we should have already been doing. So occupational health standards, making sure that the self-assessment tool that all forces have got that are signed off by experts in the field is completed, and getting those things on track consistently, Operation Hampshire, etc., etc. What we've done is we've worked for several years with the Armed Forces team who've done the Armed Forces Covenant. They're very, very keen to support us, and we've worked with them for several years. And we're now into year two, where we're starting to see new things come through that will be new for policing in this country. Specific work to support families, leavers. We've got to get a lot better at supporting people who leave us, not just in terms of psychological transition out of this job, but also in terms of the skills they may need when they move into other employment, etc., when they leave, CV writing, interview skills, etc. We've delivered bereavement counselling for those who were killed in the execution of the duty, for those families of people who were killed in the execution of the duty, and close colleagues, and suicides. But one of the things I think it is doing, the Covenant, is providing a very unfiltered view about all this stuff to the very senior people in government and policing. And it allows us to have a conversation there about the things that really matter. And you will see that some of these things are now feeding into PEEL inspections, which is very important. We're developing authorised professional practice. This is being led by Chief Constable Chris Rowley from Lancashire as the MPCC Wellbeing Lead through the College of Policing. This signals a step change in how the service regards workplace health and wellbeing. It will provide 100% clarity to every force in the country and the inspectorate about what it is that people should be doing. And there are some forces who are doing way beyond what we're writing into APP already, because there are some that are very well ahead of the pack in our view. However, we do not want to be in a position where forces who are trying to get there aren't clear on what they should be investing in. And that's the purpose of APP. And it's a very detailed piece of work that has got lots of important activities, interventions and resource in there. But it also makes the point right at the outset that we are not developing APP in order to fix the negative outcomes of a poorly run organisation. that things like resources, workload, leadership styles, culture, fairness, inclusion, all these things matter, and they drive workplace health just as much as important as having a really good trauma response model in place, which is something else that we're working on with John, people like Dr. Jess Miller and some leading forces. So I think APP is a real step forward for us, giving us that clarity. Operation Hampshire, well, the journey on this has been quite a long one, and we've got some people some forces have really stepped up over the years with Operation Hampshire, but prior to the Covenant, it was a postcode lottery, quite frankly. We now have 43 forces who all have an Operation Hampshire plan with executive level leadership. It features in Peel. So when you're inspected in your force, they are going into detail, asking questions about whether or not you're completing the Hampshire plan, and whether or not your data collection is feeding into preventative insights so that we can get ahead of the curve on police assaults, because we haven't got the full picture of data that we need yet for this, but things are getting better all the time. So one of the things that I think is really important to mention on Operation Hampshire, and I'm going to come back to this a few times, is data. We have just done a data request for forces for the data for the previous year, and we got effectively 34,000 lines of data in. The college analyst has cleansed that data, and working with Dave Brewster and experts in the field of data insights, we've actually started to put those into data insight dashboards. This allows us to start seeing for the first time patterns and trends about where assaults are happening, to who, at what time of day, in what environment, and to what severity. The point of this is so that we can start tuning in our officer safety training and also starting to intervene earlier where we see problems. For example, if we are seeing a trend peaking in assaults in custody with a certain service length of officer, then we know that we need to do more work with those officers in that environment to make sure that they have the necessary skills to protect themselves, and we're doing all we can to support them. So Operation Hampshire, we've just launched the educational online package through College Learn, and we had 7,689 people go through it so far. That's an increase of 3,000 in just a month. So you can see that lots and lots of people are starting to look at the online training packages, and the college officer safety training team are very interested in what we're doing with data. Sleep, fatigue and recovery. Right. Well, when you talk about a service under pressure, the one thing that Durham University can and do for us, because they are an independent research body and they review our survey, they conduct our survey for us, it'll say that exhaustion is the #1 issue, fatigue and exhaustion, driven by a lot of internal organisational stresses, but also the relentless nature of the job. And they can break that data down into different roles. Shift workers are far worse, as one would expect. So we've been doing some work for a few years now to try to build up our resources on the Oscar Kilo site. We have about 5,000 to 8,000 visits a month on our site, about 300 new users register every month on our site, and we've got toolkits on there. We've got packages around fatigue risk management. It's just been launched today actually on there. So we've got lots of educational stuff, but one of the things that we're also doing is a really exciting project with John Moores University, where we're starting to test the water using wearable devices on cohorts of officers, frontline officers all the way up to senior ranks. Merseyside Police have been doing a lot of work with us on this with John Moores University, but we have got a pack of forces chomping at the bit now to start testing out these devices for themselves, because with the right education and support informed by the data, and data privacy sits at the heart of this, so we have complete data privacy for individuals on this, the way we've set it up. This is groundbreaking stuff, folks. And my vision for this, our vision for this, is to get this stuff so reasonably priced and so bespoke to policing that we can issue it to people who want it when they get the stab vest, when they join the police, when they become a police staff member in a shift working role or whatever. Because we've learned a lot just working with Merseyside Police and John Moores about opportunities that we're missing, for example, with new recruits, to prepare them better for the rigours of working on shifts. The trauma tracker, this was an example of Tiff, Belinda, Sue, Paul saying, we need to get a better handle on this. I think the comment that they made to me was, you know, if every time you got out of the police car, you were punched in the nose, and then you got back in your car, went to the next job, you were punched in the nose, we would be doing something about it, quite rightly, yeah. And although we are, with Operation Hampshire, doing stuff around physical assaults, the relentless exposure to traumatic events that many of our staff experience is something that is always been a priority for us in the National Police Wellbeing Service, right? So the trauma tracker, we are working with West Yorkshire Police and Cumbria Police. John Robbins, the chief in West Yorkshire, is very passionate about this. Rob Carden, the chief in Cumbria, is the NPCC response lead, is passionate about this. We are going to be taking Jess Miller's category of traumatic incidents, pulling data out of those 4 systems and starting to look at them to identify trends, patterns, so that we can reach out to people proactively. But also, for the first time, actually see the totality of how many traumatic incidents and what type our people go to. And so there are some forces who've had a really good bash at this previously and done some great work. I know that Sussex have done this. I know the Met are looking at it, and other forces. And what we're trying to do is bring all that good work together. So we've got one consistent way of identifying traumatic events and tracking them so that we can offer better support earlier. So my final wrap up for this, folks, is before I hand over to John, is that it's, as I said at the outset, it's all very well us talking about all the things we need to do to support our people to work in this environment, but the environment itself is something that we are more aware of now in terms of what we need to do to reduce the harmful impacts of work-related issues that are controllable. So I talk about controlling the controllables, how you manage change, how you roll out technology, how you establish a fair and transparent promotion process, how you treat each other, yeah? And all the evidence that we've got focuses in on those key issues: workload, resources, you know, and there's some forces are really starting to get better at, you know, tracking and managing how much workload individuals have. And there are some good tools starting to appear from those forces that we can share across other forces to get better at this. So I'll wrap up with that. Compared to where we were 10 years ago, we know exactly what it is that we need to do in the main around the nature of the work. We have identified how the organisations run as a priority that we will continue to talk about and continue to stress to the service and also to the inspectorate, who do a lot of deep diving in these sort of areas. And we have got, I would say, 10 to 12 forces who are really at the front of the pack with this. Every force knows now that this is a big agenda item. A lot of them are committed to getting better, and our job is to share that good practice and give them the tools, guidance and support to be absolutely world class at this, because this is what our people deserve. So I'll shut up now and hand over to Professor Harrison.
Thanks, Andy. So good morning, everybody. My role is to talk about clinical governance. You may be wondering what clinical governance is and how it relates to what we're doing under the wellbeing agenda. Clinical governance is a bit of an odd term. It's well known if you work in the National Health Service, but given that we work in police forces, you might think, what is this all about? We've got 43 occupational health services in the Home Office affiliated forces, and these are all clinical services. They all work in relative isolation. Again, we've heard about the postcode lottery, and there is an issue here with respect to police occupational health services with regards to that postcode lottery. Also, as we take forward the health and wellbeing agenda, we are veering more and more into the clinical arena as we are identifying and looking to support people who are vulnerable. So the role of clinical governance and the role of the clinical governance group, which I'll talk about in a minute, is to make sure that whatever we do is safe. And we do that by aligning what we do with best practice. We want to make sure that what we do is effective, and we do that by gathering the latest research and also auditing the processes that are being implemented and looking at the impact to assess efficacy. But essentially, what it's about is about quality assurance. We want to make sure that whatever is being delivered has that required level of quality, and we do that by setting standards and then monitoring compliance with those standards. And what we're looking to do in the longer term is to drive that quality upwards. So as we meet the standards that we set, and I'll talk about occupational health standards in a minute, we then revise those quality standards upwards to drive continual quality improvement. I just want to go back a little bit to 2019, and this is the roadmap that we had in place that led to the launch of the National Police Wellbeing Service. And there were some key actions that we wanted to achieve with regards to the clinical matters that I've just been talking about. So high priority for us was about professionalising the way in which we look at professional health and wellbeing. It was developing specialist occupational health support, and that's what I want to focus on today. And it was making sure that we had good governance and measurements. So I'm talking about specialist occupational health services and the benefits that can accrue from those specialist occupational health services. So if we start off looking at, sorry, difficulty just reading that. I'm going to click on that. Sorry, I'm having difficulty just reading the slide. I think we seem to have frozen. That's coming better. Apologies, the internet seems to have frozen. So looking at the effectiveness at the front line, this is about making sure that through specialist occupational health intervention, we can ensure that we've got the right person in place at the right time to deliver. And this obviously accords to the right care, right person narrative that's going around at the moment. We also want to make sure that we understand what modern policing is about, so that we can meet the demands of those of modern policing. And that's really, I think, understanding what modern policing is about and how it impacts people's health and well-being. So by raising awareness and knowledge, we can help people meet those demands. Reducing costs is clearly an important issue here. We know that the cost of ill health is significant. So by delivering specialist occupational health and well-being, which promotes good health, good behaviours, prevents the development of ill health, identifies illness at an early stage so that we can intervene effectively, and where we have to, where there are casualties, we can ensure that there is good, effective rehabilitation. And then finally, we want to look at ill health retirement. We want to avoid early retirement due to ill health if we get everything else right, but unfortunately we don't always get that right. And we have to make sure that the processes relating to ill health retirement are good ones. We have to bear in mind here that anyone going through this process is already not in a very good place. The feedback we have had is that the current processes are not really fit for purpose and actually are detrimental to the well-being of people going through it. So one of the things we want to look at is how can we make that better? Fundamentally, it's about how do we make sure that officers and staff feel supported in line with the common goal for well-being. But above all, clinical governance is about people. want to echo what Sue said earlier. You know, every day, police officers and police staff get up and do fantastic jobs for their local community, sometimes with a detriment to themselves. So we have to understand across the wide range of policing jobs, the panoply of roles that exist, what are those health needs associated with those jobs? We can't do this in isolation. We are reliant on stakeholders to help us, and we're very grateful for the support of the Federation here and for the attendance of Sue and Paul at the clinical governance group meetings. This is a developing capability, and one of the things that we're looking to do is to create what we call a police health observatory. Andy's already talked about the importance of data. We need to collect workforce data that tells us about the health needs of our population. It's also about collating research to help inform the policy and practices that we want to develop. We're also in the process of developing a national police health and wellbeing strategy. This links into work that we're doing, linking in with the National Health Service, and mirrors some of the work that the armed forces have already done as they've taken forward their armed forces covenant. So this strategy will be the framework for delivery in the future. It will help us identify the health priorities. It will shape how we deliver our services and will identify roles and responsibilities. So here we have a plan on a page, a bit of a busy slide. It's really trying to explain to you the work of the Clinical Governance Group. It's predicated on the National Police Wellbeing Service Workforce Capability Model, whereby we start off with scanning and developing the landscape to understand what the issues are, what the evidence is telling us. That then helps us deliver services or guidance or standards in the case of the Clinical Governance Group. We can then look to measure the impact of what we're doing through assuring and evaluation. And finally, communicate what we're doing so that people are aware of it. So the big drivers for us are the Police Covenant Oversight Board and the NPCC Workforce Coordination Committee and Health and Wellbeing Board. Looking to the future, the Health Observatory will be an important driver as we collect the data to inform what we're doing. And in the fullness of time, the health and wellbeing strategy will become important in shaping what we do. If we look at the deliveries at the moment, we've got a number of work streams. An important one is the occupational health work stream, which has delivered occupational health standards. We launched the Foundation Occupational Health Standards in 2019, and over the last 4 years have been working with police forces to help them align to those standards. In March of this year, we launched new, enhanced and advanced standards, and we are now starting a transition phase to move to alignment with those standards. An important vehicle for this is the creation of our occupational health practitioner network, which is bringing together these isolated occupational health services into a single forum so that we can talk through issues necessary to meet the standards and also deal with any issues in terms of service delivery. We're also looking to produce guidance on various things, looking at medical standards. We are looking to publish medical guidance on standards for police officer recruits in spring of next year, and there will be subsequent guidance following that. We're looking at medical retirement, as I've mentioned. We are at the point now where we have agreed a new national process. We need to supplement that with guidance, and this will eventually end up on the blue light commercial knowledge management system and will be accessible to all police forces, in the hope that forces will choose to follow this route, because we think that will be better both in terms of effectiveness, but also in terms of looking after the well-being of people going through it. NHS engagement is something that we have started to do, and really addresses the issue that's been raised earlier about trying to get best support from the National Health Service for people who become unwell and really victims of the job that they're doing. There are different tiers to this particular piece of work. One is around engaging with commissioners. We're looking to do that at a local level so that chief officer teams can engage in conversations with local commissioners to say, these are the services that we need to make sure that our police officers and police staff are not disadvantaged as a consequence of the role that they do. And we've developed a toolkit to help that process, and we're currently piloting this in 3 police forces. We're also looking to address this at a national level, and with the help of the police minister, we're looking to set up a new function within NHS England, which will be dedicated to the police and fire service. And this will look to set up a partnership board, which will have oversight of healthcare commissioning, both in England and in Wales. A separate piece of work is around accreditation of healthcare provision. We're looking particularly at primary care, so that GP surgeries will become police aware, and we make sure that they fully understand the healthcare needs of police officers and police staff when they present to GPs. And we're also looking at the accreditation of mental health services as well. Finally, we've got suicide prevention and postvention. This is a very important piece of work led by Chief Inspector Dr. Yvonne Taylor. We've made good progress so far. We've got a consensus, a policing consensus about what we need to do. We launched a postvention toolkit back in October of last year, and we're currently working on an action plan for delivering support, looking at the prevention of suicide. And we've run a series of webinars already with the help of the Samaritans. We can't operate in isolation. We need stakeholders. An important stakeholder is the Police CIPD Forum. This is through workforce policy, but also because in the main, it's human resources departments that manage our occupational health services. So we need to get them on board. And the other stakeholders include the Federation, I've already mentioned you, the Police Superintendents Association. And as we move forward, we'll be working with academic partners and the third sector so that we get better access to data, we can help us with our pilots, and we can make full use of the charitable sector. When it comes to assurance and evaluation, our standards will be assessed through self-assessment. We have our blue light wellbeing framework, and we ask police forces to self-assess. And this will be backed up with collaborative work, which is ongoing with HMIC FRS, who are now looking at compliance with our standards as they carry out their PEEL assessments. We will also be auditing care pathways and policies as we move forward. A piece of work that we're doing is collaboration with the Faculty of Occupational Medicine and their CQOS accreditation system. This would give us an external kite mark of quality that will supplement our internal self-assessments of standards. And ultimately, the health service, the healthcare observatory will support us. We will communicate everything that we're doing to the oversight board, to the NPCC committees, and we'll make use of channels such as ChiefsNet and the National Police Wellbeing Service to achieve that. Clinical governance is also about change, particularly systems change. I've put up this slide here. It's a model that appeals to me. There are obviously lots of models of change, but this one appeals to me because it talks about conditions which hold back change. You can see at one level at the top, we have 3 conditions: policies, practices, and resource flows. These are what the FSG group called explicit changes. It's about structural change and are probably pretty obvious to everybody. Underneath that, we have relationships and connections and power dynamics, which again are probably fairly obvious, but perhaps a little bit less tangible. These are referred to as relational change and as being semi-explicit. And then at the bottom, we have mental models. These, again, when you think about it, probably make sense, but are less obvious and are regarded as being implicit rather than explicit. So in terms of policies and practices, we really have to start challenging some of the policies and practices that we have currently so that we can embed health and well-being within them. We take for granted now, I think, the fact that we carry out an equality impact assessment when we develop policy and practices. But what about a wellness impact assessment? I think it's also important, we talked about the postcode lottery early, to make sure that these policies and procedures lead to consistency of approach, particularly, I think, for occupational health. When we think about resource flows, we can think about policing as a £17 billion service. How much money do we actually spend on wellbeing? If we spent 1% of that £17 billion budget, we're talking about something like £170 million. Do we spend £170 million on wellbeing for something which for most forces is probably one of the top 3 priorities for forces? I'll leave that question hanging. I don't know the answer, but my belief is we probably don't. Relationships and connections are fairly self-evident. I think what's really important here is that it's not just about a top-down delivery of wellbeing. We also need a bottom-up approach. We need to develop appropriate networks. We need to develop a health and wellbeing community that will drive the whole wellbeing agenda forward. And when we think about power dynamics, we can think about internal and external dynamics. Internally, policing is we are disciplined organisations. Our go-to modus operandi is control and command. We're very task focused. And all this is really appropriate when we're in a crisis, when we have to deal with something, and that's entirely relevant. As we've heard earlier, we're often the service of last resort. But modern policing isn't just about crises. Modern policing demands modern management practices, which are focused on well-being of individuals and teams. And then finally, we get to mental models. We need to change the way people think about well-being. It's not acceptable to take for granted now discretionary efforts without building in respite, recuperation, and resilience building. I would like to change the thinking to what must I do to align myself with the wellbeing agenda, to how can I champion wellbeing in my force? How can I make my force a beacon of excellence for wellbeing for my local community? And I think occupational health is a really good example of why we need systems change. Occupational health is facing an existential crisis because we are really struggling to recruit the specialist occupational health practitioners that we need. And there are a number of reasons for this. Occupational health services tend to be organisational outliers. We know that often occupational health services are not well managed. Resourcing of occupational health is sometimes not as good as it should be. We've come across situations where some occupational health services don't even have a computer-based data management system. And that can't be acceptable in 2023. We need data management systems so that we can look at the performance of our occupational health services, but also understand the health needs of our populations. So I think the time has come where we really need a business processing re-engineering approach to occupational health. We've got to ask ourselves, what is occupational health about? What's the best way of delivering it? And how do we resource that? And I want to finish really by summarising what I've said so far and leaving you with a thought. In conclusion, clinical governance is about the safe and effective delivery of clinical services. So these services are quality assured and will be underpinned by continual quality improvement. We deliver guidance, we deliver standards which are aimed at the entire employee journey from recruitment to retirement. And we need to make sure that these are relevant to the needs of frontline policing. It's also about systems change. So I've talked about why we need to do things differently if we are going to ensure that we achieve the health and wellbeing vision and that health and wellbeing becomes a core capability. And an acute example of this is the problems facing police occupational health. It's often said that we struggle to take the wellbeing agenda forward because of lack of resources. I think this is true in part, but it's not the only story. I think there's a collective lack of belief, a collective lack of imagination, and a collective lack of commitment. A lack of belief in the importance of well-being and about the benefits that can accrue from it. A lack of imagination in terms of what good looks like. To quote Paul, I can't remember his name now, senior moment, the former chair of the What Works Centre for Wellbeing, it's not just about apples and Pilates. We have to take a holistic view of well-being. We have to take a systems view of this. And then a lack of commitment to change. The College of Policing talks about leadership, professionalism, and consistency. And I think we really have to take that on board. So the battle really is about achieving that collective belief, imagination, and commitment. And I think if we can get to that point, we will have won the battle. I'm going to stop at that point.
John, thank you very much indeed, and thank you to Andy as well. Both are staying with us. We may have time to squeeze in some questions. Before we do, let's hear from the Wellbeing co-lead at the Federation, Paul Williams. Paul.
Thanks, Ian. Thanks for our speakers for delivering today, and thank you also for your continued hard work in this subject area. I'm going to spend a short time summarising the subject of wellbeing in policing today and the potential impact. The evidence speaks for itself, and in the current situation we have to ask ourselves, is the light at the end of the tunnel? We see some interesting but unsurprising statistics around the wellbeing of our officers. These stats paint a stark and grim reality of the challenges we currently face. But even without these statistics, the situation seems obvious to all of us. Whether we choose to believe it or not, this is staring us all in the face and is a real risk for the future of policing. As Sue touched on earlier, assaults on our officers continue to rise by a staggering degree. Up to date, between 2022 and 2023, over 29,000 assaults without physical injury, with over 11,000 more with physical injury. And as we know, there is still work to do on accuracy of recording and gathering this data. That's over 40,000 assaults in a year. Verbal and physical abuse is almost the daily norm. Any member of the public suffering this so often will be rightly considered a repeat victim and would surely have their mental health impacted upon. Yet our officers face this on an almost daily basis for years or even decades throughout their career. But there is still that assumption by many that this is just part of being a cop and we should not expect anything else. This is wrong. It cannot be an acceptable culture. This, along with extremely traumatic incidents, dealing with death of all nature, horrific crime, and unimaginable workloads with increased bureaucracy, all under intense scrutiny and trial by social media. Is it any wonder that there is also an increase in mental illness in our policing society today? Even more stark is the disturbing increase in our colleagues taking their own lives. Between 2001 and 2020, 344 of our colleagues took their own lives, averaged at 17.2 per year, more than one per month. This number is rising. This issue is serious and real, and the well-being of our cops needs real time and real investment. PTSD, acute stress disorder, anxiety, depression, are just a few of the illnesses that we're seeing regularly amongst our colleagues. And these, if not managed, breaks us beyond repair. Conference, these are our silent and deadly cop killers. This all seems grim, but we are seeing some examples by some forces of significant investment in wellbeing and trauma management. As you have heard, there is better recognition, better acknowledgement, and stakeholders in wellbeing are increasing. That said, the really good practice by some needs to be by all. And there is a huge amount of work to do to make improvements to not only infrastructure to make this happen, but overall attitudes. Wellbeing management is the difference between good health and bad health. It's the difference between a good public service and bad public service. It's the difference between life and death. I've heard more than once a model or hierarchy used by chief constables and other senior figures in policing. It's public first, organisation, then staff. Whilst considering there may or may not be a wider context to this model, I want you for a time to consider moving the former to the latter and vice versa. Because conference, given the strong evidence, if our country's police officers' welfare is not a priority, then we won't have an organisation fit or functional to serve the public. How can there be a hierarchy if the police are the public and the public are the police? If I could appeal on this conference to the Home Secretary for anything, it would be to invest with meaning in looking after those who look after the public. If it's expected that policing means running towards danger, taking verbal and physical abuse and enormous trauma exposure, then at least take them from the bottom of the pile and provide appropriate and meaningful welfare support with an insistence on mandatory framework of support for forces. Conference, thank you for listening.
Paul, thank you very much indeed. We have around about 8 or 9 minutes or so left of this session, so it would be appropriate to take some questions that have come through to our panel. Let's start with one that is reflected in many of those inquiries or questions that came through. Do the panel think that the police covenant goes far enough to really look at the physical and psychological welfare of officers? If not, what is missing? Sue.
So the simple answer is no, we don't think it goes far enough at this stage. It needs some real investment in the covenant. We do have a good example, I think, in the military covenant. You know, we have seen the creation of Professor John Harrison's post, but we're not seeing changes or investment financially. So we would definitely like to see the covenant go a lot further.
Yeah. Andy Rhodes, do you want to give us a response on that?
So I agree, because what you find across the services that are out there being provided for police officers and staff is that they're under pressure themselves, right? There isn't enough capacity in the system. Sometimes they're not delivered, as Sue and Paul said, quickly enough or consistently enough. So we think that there is a need to leverage that support into the covenant from the NHS, but we also think there are options to do some things once nationally, driven by the covenant, that make sure we get that 100% consistency of service around particularly the critical things that our staff need. Support, we've talked about suicide, we've talked about trauma support, talking therapies, getting people back to work quicker. These are the things where I think we've got more work to do.
And Professor Harrison, just to put that question to you, what is your response?
I'll echo what's been said already. I think I see it's early days yet. The covenant hasn't been around very long, and I think we're still getting our head around what it is we can do. I think we have to be ambitious about what the covenant can achieve. So I see it as a leverage and a sort of an enabling opportunity, and I think it's down to us to put our ideas together and then to challenge government to resource what we would like to achieve.
Let's try and squeeze in another question or two if we can. Here's one from Dan Smith, who says, currently in my force, when an officer is physically assaulted, their line manager has to complete a 9-point plan to ensure their well-being immediately after the incident. There is nothing immediately in place when an officer is exposed to a traumatic incident that has a massive effect on their mental health other than local wellbeing services, which are mostly self-referral. Why is there not a nationally agreed 9-point plan in place for these types of incidents, and is this something the College of Policing could look to introduce? I'll come obviously to Andy on that in just a second. Paul, are you familiar with that kind of question?
Yes. Unfortunately, we've got 43 different forces who do 43 different things and record 43 different things 43 different ways. And the recording of assaults of varying nature are done in a varying manner. And this is what we're trying to achieve by Up Hampshire. But that said, mental illness and mental health and trauma is very hard to measure because it's unseen. Yeah. It sometimes doesn't onset until way after the actual incident takes place. Some forces employ a TRIM, a trauma management, but again there are varying standards on how that's recorded, how it's monitored and how the aftercare is put in place. And I would very much support that question. I would very much support the fact that there has to be more work done around trauma management and mental health. It's entirely linked. It's a danger to the workforce. It's a danger to costs through potential long-term illness and ill health retirement. And early management is early addressing and early cure. Yeah. And I would absolutely support that suggestion that more needs to be done.
And Andy Rhodes, Dan, in his question there, did ask if it's something, he talked about a 9-point plan that is in place. Is that something that could be rolled out nationally, and could the college introduce that?
I think this is where we're heading with trauma support. I think whilst assaults, you know, Dave Brewster would say that an assault is a traumatic event, of course, so you will get a better support package when you're assaulted around the trauma of being assaulted, but for the traumatic exposure, we will have in APP, Authorised Professional Practice, a trauma support model that basically explains to forces with all the links to the different support packages and training programs that are available, ranging from TRIM through to psychological risk assessments, etc., and the trauma tracker, exactly what a good, safe system of working looks like for trauma exposure. What we see across the world, to varying degrees, is some larger police forces establishing very similar systems of working around trauma that we do to physical risk. And that is where we need to get to, right? There is no stab vest for the mind as it is. As it stands, and so we need to do more to educate our people, but we all need to have a safe system of working in, and the Health and Safety Executive are going down that route as well. You know, so I think fatigue and trauma exposure are two areas where we've got more work to do.
And a final one I think we can just squeeze in here from Liz Groom, who says officers need access to food, canteens, time to rest and debrief traumatic incidents. They are simply not afforded the time to even debrief or talk to each other. Forces have cut things that help improve welfare, like access to canteens due to cuts. Do the panel agree that we need specific and significant ring-fence funding for welfare? Sue, and that's a really good point, isn't it? I know we've not got long on this, but the idea of just to chew the fat with a colleague, talk it over.
Absolutely. Absolutely right, Liz, that they have taken away canteens, and that is the opportunity to debrief. But also what we mustn't forget is actually officers are routinely going from one incident to another incident. So there isn't even that opportunity to debrief, but we need to make that time. And I think this is where executive and senior managers do need to come in and ensure that officers are given time to take their lunch break, and there absolutely should be facilities within the stations to allow that to happen. So it's definitely something we're looking at as a federation. We're going to be ensuring what's out there for our officers across the country. But yes, it does need that financial investment. We need to start to look at how officers do debrief, but more importantly, giving them the time to be able to debrief.
Professor Harrison, final point, although even from a non-clinician will be able to see that debriefing and having those moments, and as Sue said, particularly in between incidents, the idea that you haven't got 5 minutes to sit down, even get your own head together, let alone chat it over with a colleague. But that's surely a crucial part of the process.
Absolutely. I mean, it's not rocket science, is it? And I have these conversations all the time, and I know that people at different levels of the organisation all agree with this. I think the challenge is how do we actually put it into practice and reverse some of these changes that have taken place over the last 10, 20 years.
And on that point, thank you to Professor John Harrison. Thank you to Andy Rhodes as well, both from, of course, the College of Policing. Thank you to Sue. Thank you to Paul. Good to see you both. And we are going to move on